Good afternoon, everyone, and thank you so much for being here today. I'm Dr. Kim Newell-Green, and I'll be the moderator for today's virtual Grand Rounds, which is entitled Fentanyl and Tranq, or Xylazine, Emerging Threats in Illicit Drug Use. Next slide, please. We want to acknowledge CDPH as our partner in providing relevant public health education for physicians in California. Next slide, please. Oh, and just before you go to the next slide, you guys noticed our speakers' disclosures. And next slide, please. As you may remember, this series is accredited for CME credit. You'll be sent a survey upon the completion of the webinar where you can attest to your attendance. And upon the completion of your survey, we'll send out your certificate. So please be sure to do that. Here are our topics today. Next slide, please. And our learning objectives. Next slide, please. Actually, let's go back to that last slide. So as you may have all noticed, as we evolve this series to include issues outside of COVID-19, we will generally continue to have our regular guest, Dr. Erica Pon, join us for updates of COVID as well as other emerging public health issues. One of the attendees today asked, what are emerging public health issues? And that's what we'll find out. The idea is that we have now a format for updating all of you as clinicians in California on COVID, as well as other infectious diseases and any other clinically relevant news from public health. So we think it's an exciting format. And today's topic is a great example of that. Today, Dr. Pon isn't available to join us for our epidemiology report, so we're going to jump right into our main topic. We're all aware that we're in an evolving opioid crisis. Fentanyl itself is a deadly drug threat, and it's overwhelmed our country in the past few years. However, Xylazine, a powerful sedative used in veterinary medicine, has now entered the scene, and it's increasingly mixed into the fentanyl that's sold on the streets. And this mixture has increased the risk of fatal drug poisoning. Today's conversation will feature these two experts who are to help us discuss this rapidly evolving crisis. We have Robin Christensen from the California Department of Public Health and Dr. Jeffrey Home from the San Francisco Department of Public Health. We're pleased to introduce first Robin Christensen. Robin is the Chief of Substance and Addiction Prevention Branch at the California Department of Public Health, where she leads several initiatives addressing overdose, cannabis, alcohol, and problem gambling. She received her Master's of Science in Public Health from the Harvard T. Chan School of Public Health and has worked in public health for over 20 years. Robin's work aims to reduce individual, social, and environmental harms caused by substance misuse and addiction through research-driven prevention, education, and treatment. And we're grateful to have you here today, Robin. So go ahead and tell us everything you know.
Thank you so much. Next slide, please. So yes, as the introduction said, my name is Robin Christensen. Thank you to CMA for the honorary doctorate. I am actually just Robin Christensen, Ms. Robin Christensen without the DR in front of it. I am here to talk today about the public health perspective of the emerging threats in illicit drug use with a focus particularly on xylazine. Next slide, please. So just to ground us a bit, where we're at in terms of overdose and fentanyl in particular. So in 2021, which is the most recent year for which we have complete data, California experienced over 7,000 opioid-related overdose deaths, with most of these deaths, nearly 6,000, related to fentanyl. When you compare this to the national landscape, our numbers are certainly by count higher than what you see in other states. So that is due in large part to the size of our population. When we look at rates and we compare California to other states, we actually fall right around the middle in terms of the burden of opioid overdose in California as compared to the nation. So this is both tragic and costly. We also see that there's nearly 21,000 emergency department visits in 2021 that have been related to opioid overdose. Next slide, please. And when we start to dig a little deeper into the data, we notice a number of trends and disparities. So I want to point out a few things on this slide. First, the majority of opioid-related overdose death occurs between the ages of 25 and 44. And then there's another uptick that occurs in our 50s, so sort of that slightly older age range. Please also notice that there are sharp increases over time from 2018 to 2021 among our younger populations, the 15 to 24-year-old age range. So opioid overdose and opioid misuse is now trending younger, and while the overall population burden is still among adults, it's critical that clinicians be aware of treatment for the pediatric population as well. Next slide, please. When we start to break it down by race and ethnicity, we can see it impacts everyone. Overdose impacts absolutely everyone, regardless of race or ethnicity. There are disparate impacts on the Black and African American population, and also the Native American, Alaska Native populations as well. Next slide, please. Now, fentanyl drives most opioid overdose deaths, not just in California, but nationwide. And as a clinician, you may be wondering why people are using fentanyl recreationally. For some, it's absolutely unintentional, with fentanyl ending up contaminating other drugs in order to make them cheaper or to make them more powerful. It ends up in products such as methamphetamine, cocaine, or in fake pills that can be purchased on the street or online. It is also mixed with heroin, and that is one pathway in which people become addicted to fentanyl. For many people, it is an intentional drug use. Once fentanyl is in the drug market, given that it is so easy to consume, easy to access, some users will quickly become addicted to fentanyl and seek it out over heroin. Others seek out fentanyl because that's all that they have available to them in their drug market, and they are living with an active, untreated opioid use disorder. Next slide, please. Fentanyl as an emerging issue has really been a landmark shift in our drug landscape over the past decade. Once in the market, and we started tracking this around 2011, really low levels at first. And then as testing became more common and as the drug market quickly changed, we started to notice a shift very rapidly over time in the number of fentanyl-related opioid overdose deaths. Fentanyl is incredibly cheap. It's easy to transport, it's easy to hide, and a very small amount of the substance can have a euphoric effect, meaning that there's less risk to traffickers and to distributors, and there's an opportunity for increased profits as well. In terms of geographic distribution, there's not a single corner of the state that's immune. Fentanyl-related overdose deaths have been measured everywhere, even in tiny Alpine County, population 1,100, which is that rather dark red blotch up near where Tahoe would be. So this map shows the rate of fentanyl-related overdose per 100,000 population. And the population, next slide, please. The population using fentanyl skews a little bit younger than what we see of those using heroin. So in the prior slide shared just a few back, we saw almost that camel-shaped V curve with both a younger audience and also older people dying of any opioid-related overdose deaths. With fentanyl, however, we're primarily talking about a younger age range. These are 20 to 34-year-old age range. Next slide, please. The trends by race ethnicity remain the same as those for all opioids, yet they each show even more disparities, with the difference between African American and Native American populations being even more dramatic. So fentanyl-related overdose deaths impact Black and African Americans at a rate 50% higher than whites, and Native Americans at a rate almost 75% higher than whites. This almost certainly reflects the disparities in our access to information, prevention, harm reduction, and treatment, and also reflects the multifactorial causes that lead people to using drugs in the first place, including poverty and homelessness. Next slide, please. So, what is xylazine? It is used as a veterinary medicine and really for large animals. We're not talking about cats and dogs. This is a veterinary medicine that's used for horses and large animals. There has never been an approved human use. Xylazine is almost exclusively combined with fentanyl, and symptoms of xylazine exposure include sedation, slowed breathing, reduced blood pressure, and effects on circulation. Regular and prolonged use leads to skin and soft tissue use, and withdrawal is different. So coming off of xylazine is a different experience than that of coming off of opioids or methamphetamines. Next slide, please. In terms of the timeline, it was first developed in 1962, and it wasn't really detected in the drug supply or reported on in the drug supply until Puerto Rico in the early 2000s. It wasn't until 2019, 2020 that reports of xylazine in the drug supply started to emerge on the East Coast. It almost certainly was there earlier. This is when people started to take notice, start to detect, and start to report out that xylazine was in the supply. In November of 2022, the FDA warned everyone about the risks of xylazine exposure to humans. They issued a Dear Colleague letter to raise awareness. And shortly thereafter, in April of 2023, the Biden-Harris administration designated fentanyl combined with xylazine as an emerging threat. And this was too recent for these slides, but just yesterday, they released their national response plan in response to fentanyl associated with xylazine. So next slide, please. As we were watching this issue unfold, California and the Department of Public Health has been tracking this issue since about 2020, when we were still thinking about this as being a relatively isolated issue on the East Coast. So why is fentanyl, an already cheap product, being cut with xylazine? And we have a few theories about why xylazine is contaminating the drug supply. Generally, cutting agents are used to increase profits. And the cost of fentanyl is a really dynamic sort of variable. It goes up and down with market forces and what is going on in the larger drug market. It is also prone to regional variation. And so as the cost of fentanyl increases in one region, there can be stronger pressures on the market to cut with agents such as xylazine. There's also the theory that given fentanyl's relatively short half-life relative to heroin, xylazine has the potential to prolong the desired effect of fentanyl, and I've seen this repeated a few places. We think it is more likely that it is actually delaying the perception of fentanyl withdrawal. So none of our current reports within the state of California Department of Public Health indicate that xylazine is added because people who use drugs are intentionally seeking it out. They don't want it. They may end up using xylazine and even become addicted to it, but it is generally not a preferred product. Our work with community-based organizations serving people who use drugs has found that xylazine is here. We have done a number of investigations in terms of drug checking, and we find that while it is present in the population, it isn't here in very prevalent amounts. It still seems to be relatively low level at this point in time. Next slide, please. This also reflects what we're seeing in the mortality data. So within the state of California, we work with a number of counties. We work with their coroners and medical examiners, and we work with 23 participating counties. That's the suitors participating counties. And we did a deep dive analyzing each of the reports to look for any mention of xylazine on toxicology reports or anything in the notes. And less than 1% of overdose deaths in 2021 indicated that xylazine was present. San Francisco did a deep dive into their own cases, looking at retroactively testing their fatal overdose cases for xylazine. So this was more of a systematic review where they analyzed all of the cases during that period of time, and they retested them to see if xylazine was present. They found that less than 3% had xylazine present. Santa Clara identified one death associated with xylazine. Also, other substances were present. And I think the important thing to note here is that testing remains inconsistent. So approximately half of California's coroners and medical examiners report that they do test for xylazine or have the ability to test for xylazine. It doesn't mean that it's done consistently on every overdose case every time. So both our numerator and denominator are a little bit in flux here. Next slide, please. So given all of the information that we have available to us, we are currently characterizing xylazine as not yet prevalent in our state's drug supply, but we want to be prepared. We want to be as prepared as possible here. So if you think back to that first slide shared with fentanyl's onset in California, when the new substance enters the market, it really has the potential to quickly take off and establish permanency. So we do think that there's some reasons to think that there's some protective factors here in California. Historically, the cost of fentanyl here has been lower than it is on the East Coast, which may help with some of those market forces. Our regional supply chain is different from that on the East Coast, and there are higher rates of smoking fentanyl in California as compared to other states. But of course, anything regarding the drug supply can change at any time. So CDPH has been working to raise awareness of xylazine, including a number of resources that we've sent out to clinicians and the general public. Next slide, please. One resource in particular, the California Health Alert Network, the CAHAN, shares information and outlines steps that healthcare providers should do, which Jeff will provide more detail on. In general, we're asking that healthcare providers should maintain a level of suspicion of xylazine exposure when naloxone appears to be ineffective in reversing a suspected drug overdose, particularly when multiple doses of naloxone have been used. We are also looking for necrotic skin ulcerations being present with a person with known substance use disorder, especially opioid use disorder. Mostly the clinical management comes down to supportive care. Again, Jeff will describe more of that. Now, testing for xylazine may be available for retrospective confirmation of suspected xylazine poisoning. This will depend largely on your local hospital and laboratory, and it can be considered. As of this notice, as of this webinar today, there is no current Food and Drug Administration approved laboratory test for xylazine. There is no point of care test for xylazine. These are all things that, as part of the National Response Plan to xylazine, the federal government is looking into developing more rapid point of care tests to look into xylazine. They are not available yet, though. We are currently aware of 2 commercial laboratories that do accept clinical samples and can detect exposure to xylazine, LabCorp and NMS, which generally does forensic toxicology. In terms, let's see, the CAHAN and all of these resources that we're sharing here, the issue brief, the letter to local health officers, and xylazine fact sheet, all of these are available on our website, which is the very next slide. Thank you. So our CDPH website is the hub for all of our information related to xylazine. So I think that after this webinar, if you are interested in learning more, this would be the primary point to go to for resources about California's response to xylazine. We're also updating this webpage frequently with new resources and information as they become available. We're closely tracking the federal situation, and we'll be providing updated resources as they are released from the federal partners. And next slide, please. And in terms of what is next, we know that xylazine is today's emerging issue in substance use disorder. But as a department and as a state, we are also seeking to improve our surveillance of other emerging substances. So there are new synthetic fentanyl analogs like carfentanil. There are things known as nitazines, or they're called ISO sometimes. And then there are also some under the radar products like tianeptine and kratom that people may be having access to and are using in a substance abuse manner. We're also monitoring changing trends in drug consumption, including notable trends towards increased polysubstance use or intentional mixing of substances, which certainly complicates our overdose response strategy. And with that, I think that is my final slide, and I'm turning it over to Jeff.
Thanks so much, Robin. That was super informative. And now we look forward to hearing from Dr. Jeff Holm. So I'll give a brief introduction and then you can take it away. Jeffrey Holm, MD, MPH, and MSHP is the Director of the Population Behavioral Health Section of the Division of Behavioral Health at the San Francisco Department of Public Health, which uses population-level and equity-driven approaches to address the behavioral health challenges and promote the well-being of San Franciscans. A board-certified internist, Jeff oversees the department's Office of Overdose Prevention, focusing on reducing overdoses and the individual and collective harms associated with risky substance use. Prior to this job, Jeff served as the medical director of the Division of Substance Use Prevention and Harm Reduction in the Philadelphia Department of Public Health, establishing the division and helping lead the city's response to addiction and overdose. So he's a great source of information on sort of the epidemiology and supply chain issues that are different across the country. So we're very grateful to have you here today, Jeff. Take it away.
Great, thank you very much, Kim, and good afternoon, everyone. Thank you to CMA for the opportunity to really be here. It's a privilege to present with Robin, my colleague in the State Health Department, whom I'm certainly fortunate to work with and learn from. And really, most importantly, thank you all for joining today. Next slide, please. So here's an overview of what I'll spend the next few minutes discussing. I'll follow up on some of the comments that Robin introduced, talking about the changing drug supply and its health implications, and then delve a little bit more deeply into sort of what are the implications for us as clinicians around thinking about fentanyl use and fentanyl exposure, as well as xylazine exposure. And I'll end with some concluding thoughts about what we all can do to support and provide care to people who use drugs. Next slide, please. So this slide builds upon one of the themes that Robin sort of ended with there, is that our unregulated drug supply has changed and it will continue to change. And so this is a timeline of, over the last several years, what have some of these threats been that we have seen across the country? So back in 2016, many of you may be familiar with this concern that came up around carfentanil. The DEA issued a warning to police and the public. Carfentanil is a very potent opioid, far more potent than fentanyl, oftentimes known as an elephant tranquilizer. And that had made its appearance in a couple of isolated cases around the country. Nonetheless, there was certainly a concern that it could spread more widely throughout our supply across the country. And so the DEA did issue this warning. A few years later, back in 2018, some of you may remember these clusters of outbreaks that were related to synthetic cannabinoids, and specifically synthetic cannabinoid-associated coagulopathies. This one that I pulled from the New England Journal was about an outbreak in Illinois, but there were other sort of reports that were happening around the country as well associated with synthetic cannabinoids. Synthetic cannabinoids the use of them seems to have decreased in the last couple of years, but certainly then replaced by another novel drug that is making its way into our supply nationally. So then in 2021, there is this report that was published in the International Journal of Drug Policy that was sort of talking about novel psychoactive benzodiazepines, not ones that are used for pharmaceutical purposes, but that made their way into, again, this unregulated drug supply. And that leads us to 2023, where we are today, with confronting, as this Healthline article points out, California confronts the threat of Tranq as overdose crisis rages. Next slide, please. So I'm going to spend the first few minutes here sort of really focusing on fentanyl and fentanyl analogs. As Robin mentioned, these are synthetic opioids that are much more potent than morphine and heroin, 50 to 100 times stronger than morphine itself. And this is sort of illustrated in this picture on the left here, in which that small amount of fentanyl next to that penny for reference is enough to cause a fatal overdose in an adult with no sort of opioid tolerance. Use may be intentional, but accidental exposure and overdose is possible when fentanyl is added to other drugs, such as heroin, cocaine, or as Robin mentioned, is pressed into pills. Next slide. Fentanyl is unique in many regards in terms of its mechanism of action and its absorption. It is an opioid, it's a synthetic opioid, but it does differ from other opioids that we might prescribe for pain relief in clinical medicine. And so its duration of action, its potency, and its absorption all have pushed us to sort of think about what are the new ways in which we can respond to this crisis, both from a clinical point of view as well as a public health point of view. And so the first of these is that the duration of action is very short. As many of you know who have prescribed this or utilized this in the care of your patients, the duration of action is in the order of minutes. So when injected, it's 30 to 60 minutes. Therefore, individuals with severe fentanyl use disorder are cycling very rapidly between feeling well and experiencing withdrawal from fentanyl. This going back and forth means that people who use fentanyl regularly must use much more frequently compared to other opioids. And so as Kim mentioned during my introduction, I spent the last 6 years in the Philadelphia Department of Public Health, where use of fentanyl was very common. And it wasn't uncommon, though, to hear people having to inject fentanyl 12, 13, 14 times a day in order to stave off these withdrawal symptoms. Whereas before, when heroin was the predominant opioid, maybe people were injecting 3, 4, maybe 5 times a day. And so now individuals who are having to utilize fentanyl so much more frequently are at risk of perhaps reusing their syringes or their supplies if those needs are not met. And that then puts them at heightened risk for HIV, hepatitis C, and other skin and soft tissue infections. And that's what this graph on the right shows. So this graph is from the National Health Behavior Survey. This was when I was in Philadelphia, and this was conducted by the Philadelphia Department of Public Health. This is a survey that is done every 3 years, as you can sort of see there. And what it's asking are the individuals who use drugs, what is their frequency of using clean syringes in the past 12 months? And you can see back in 2012, the majority of people were reporting always or most of the time using clean syringes. Fast forward 6 years, you can see now more and more individuals are reporting using sterile syringes only half the time, or rarely or never. And so this trend, which was sort of consistent with the introduction of fentanyl in Philadelphia supply, illustrates how we need to sort of think about meeting the needs of individuals who are actively using drugs to ensure that they have sterile supplies if they are injecting, if they are smoking, to reduce their risk of contracting HIV, hepatitis C, or incurring skin infections by virtue of them reusing or sharing their supplies. Next slide, please. Then there are also real significant implications for how we treat individuals with severe fentanyl use disorder. As you would expect, based on the potency of fentanyl, people with severe fentanyl use disorder have very high tolerances to opioids. And anecdotally, some individuals are who are seeking treatment for OUD, prefer methadone over buprenorphine. It is a full agonist compared to the partial agonist that is buprenorphine. And so for a lot of individuals, they believe that that will help address their cravings, help address their withdrawal symptoms better than buprenorphine. However, our OTPs, our methadone programs across the state, aren't necessarily comfortable and accustomed to providing such high doses to meet the needs of individuals with severe fentanyl use disorder. And so that is one area where we need to sort of think about is our clinical response changing in response to the widespread use of fentanyl that we see across the state. And so higher doses of methadone are often needed to reduce these cravings and withdrawal. And we need to think about that as we titrate people up. It may not be enough to just give them that low dose 30 milligrams or so on their first day or their second day. How do we get them up really quickly to a dose that will actually address their cravings and their withdrawal symptoms to ensure that we not only start them on treatment, that we really can truly engage them and retain them on treatment as well. Next slide, please. And then there's buprenorphine. So buprenorphine, as you all know, is another one of the FDA-approved medications for treating OUD. I will say that buprenorphine can be used to treat fentanyl use disorder, but that new dosing strategies may be required. So while we do anecdotally hear of individuals who are preferring methadone over buprenorphine because it is a full agonist, many individuals who use opioids today, including those who use fentanyl, could really still benefit from buprenorphine. However, we do need to think about dosing strategies a little bit differently. The paper that I've pulled here was an article from 2019, written by some clinicians out in Boston at Massachusetts General Hospital. And what they sort of looked at here was how has fentanyl use changed buprenorphine treatment retention and abstinence from other opioids. And they did find that buprenorphine treatment and abstinence among those who were retaining treatment is not worse between people who are using fentanyl compared to heroin at treatment initiation. Both groups have lower abstinence rates at 6 months compared to individuals with negative toxicology at baseline. These findings suggest that people exposed to fentanyl still benefit from buprenorphine treatment. And I really wanted to make that point during these grand rounds here because there is this perception perhaps that buprenorphine isn't going to be effective, so there isn't use in actually even trying it. I really want to dispel that because buprenorphine is a very important, very effective medication. Next slide. But our dosing does need to be rethought, perhaps, in light of how fentanyl is absorbed by the body. There's a lot of belief, and some literature to certainly substantiate that one of the challenges with buprenorphine and sort of starting someone on buprenorphine is that fentanyl, compared to other opioids, is that fentanyl is very lipophilic. It is absorbed by the fat in our bodies, and it develops something in the way of a reservoir that slowly then sort of leaks out in the absence of taking fentanyl consistently. Therefore, because you always have sort of a low, perhaps circulating amount that is leaching out of the fat supply in your body, any amount of buprenorphine is enough to put you into precipitated withdrawal. And so that sort of unique feature of fentanyl is one of the reasons why some of these new dosing strategies have developed. And so there's two sort of conflicting in some ways, but I'll describe both of them here, different ways of approaching buprenorphine use in individuals with severe fentanyl use disorder. The first of these is on this slide here, and it's sort of a low-dose initiation or microdosing approach to buprenorphine. It is effective and can reduce the risk of precipitated withdrawal. One of the protocols is on here. There are a couple that are out there, been shown to also be effective. This is one that we are using within the San Francisco Department of Public Health. I am actually in an office on 1380 Howard, above the pharmacy and above the clinic, that was really sort of pioneering this work here, and sort of hence the title of this paper on the left, the Howard Street Method, a community pharmacy-led low-dose overlap buprenorphine initiation protocol for individuals using fentanyl. And so I won't go into the entire protocol here, but the table of it is on the right here. It basically shows that you are slowly introducing someone to buprenorphine. As opposed to the sort of the traditional buprenorphine protocol, you're giving them much less in a way of slowly getting their body used to having a partial agonist in their system, and that slowly replaces the full agonist, fentanyl or other opioids that are on their mu receptor. And by slowly replacing it, as opposed to replacing it all at once, you're reducing their risk of having precipitated withdrawal. Next slide, please. On the other end of the spectrum is this idea of sort of high dose initiation. And this is something that some of you may have heard about and has been called sort of macro dosing, and can also be appropriate for patients who are using fentanyl. And so this paper on the left, the title and the authors, a lot of work has been done out in Oakland, here in the Bay Area, but it's high dose buprenorphine induction in the emergency department for treatment of opioid use disorder. And then this protocol is here on the right. But the idea here is that you are introducing a much larger amount to sort of quickly saturate receptors, get someone ideally over some of the precipitated withdrawal they may initially experience, and get them to the point where they are comfortable and stable on the medication. So there are sort of a couple of different ways in which we had sort of thought about this. But the important thing that I also want to emphasize here is that our understanding of how this medicine can be used is still evolving. But we shouldn't be giving up on this medication, because there are ways in which we can help individuals with severe fentanyl use disorder get onto medications for opioid use disorder, whether that is buprenorphine or methadone. Next slide, please. And that is sort of what is seen on this slide here. Despite this new learning curve with buprenorphine, we really encourage clinicians to treat OUD in their practices. Buprenorphine, like methadone, can reduce the risk of death by 40 to 50%. As many of you know, the X waiver is no longer required to prescribe buprenorphine to treat OUD as of earlier this year. This had long been a barrier to people wanting to prescribe buprenorphine for treating OUD, but it is one less barrier. It was removed earlier on, or late last year, and went into effect early this year. And so anyone who has a DEA certification can prescribe buprenorphine for the purpose of treating OUD. And this is beneficial because, unlike methadone, when treating OUD, buprenorphine can be dispensed from retail pharmacies. It does not require an individual to go to an opioid treatment program. A lot of the data in support of this and really prioritizing the use of medications for OUD comes from this consensus study report that is shown here on the left, that was published a couple of years or so ago from the National Academies of Sciences, Engineering, and Medicine. And is a really very worthwhile and very readable report that was published, and has a lot of the evidence behind both buprenorphine and methadone, should you be interested in reading it. Next slide, please. I think this is one of my last slides about fentanyl, and then I'll move into talking about xylazine. But the one thing I want to sort of emphasize here around is about fentanyl overdoses. As much as we think about fentanyl, treating fentanyl use disorder, sort of what I covered on the previous couple of slides here, is that individuals who use fentanyl are still at very high risk for having an opioid-related overdose. And there has been concern of that, are fentanyl overdoses treated? Can they be treated with naloxone? And I will say unequivocally, yes. It is important to get naloxone and administer it in a timely way, but when administered in a timely manner, it can indeed reverse the effects of fentanyl. There are no known naloxone-resistant fentanyls that are out there. I know occasionally this makes its way into the newspaper, but there are no known naloxone or Narcan-resistant opioids. If naloxone doesn't appear to work, it may be because it was administered too late, or there may be non-opioids that the person had also taken that are not going to be reversed by naloxone. But just because it doesn't appear to immediately work does not mean that the opioid or the fentanyl was resistant to the effects of naloxone. And so then there's this point here that I'm sort of making with this paper here is a question comes up often is, well, how much naloxone should I give for someone who may be using fentanyl? So fentanyl, like other opioids, can again be reversed with naloxone. Higher doses or more frequent dosing of naloxone do not appear to be required, provided that naloxone is given quickly upon finding someone who may have overdosed from fentanyl. And so data from this, data supporting that come from this observational study from a syringe access program in Pittsburgh, Pennsylvania. And these authors looked at between 2013 and 2016, the percent of opioid overdose deaths involving fentanyl increased from 4% to 69%. So this huge increase that we have now certainly seen in California among the number of overdose deaths that have involved fentanyl. But despite that increase in fentanyl's prevalence in Pittsburgh, the average number of naloxone doses needed to remain stable and needed to reverse an overdose remained stable. It was 1.56 on average across all of those 4 years. So despite this increase in fentanyl, the number of naloxones remained the same. So I really want to sort of emphasize again just the importance of having naloxone around if you know someone who might be at risk of an overdose, including one that involves fentanyl, is to administer naloxone. Even if you are not sure what drug the person may have taken, it is important to give. It very well could be life-saving. Next slide, please. And then my last slide here around fentanyl is around fentanyl test strips. These have sort of been designed for urine drug testing, but have really been found to have a role in educating and alerting people about the presence of fentanyl in their drugs. And so for those of you who have not sort of seen a fentanyl test strip before, an image of this is on the left. These are, you would take one of these strips and dip the bottom lines there, and sort of that where the wavy blue lines are at the bottom there. You would dip that into a sample of drugs. And then within 1 to 2 minutes, you would know by these indicator strips seen in there in the test area, whether or not fentanyl or one of the common fentanyl analogs was present. So now we are all sort of very familiar with this idea of a rapid test based on either pregnancy tests or COVID tests. These operate under similar principles. The idea being that within a few minutes, you'd be able to identify qualitatively if fentanyl or one of the common fentanyl analogs is present. I am careful to sort of say that because these are not quantitative tests. They do not tell you how much fentanyl is in the supply that you're testing, only whether or not it is present. So these tests do have limitations. Nonetheless, the literature suggests that they can be helpful in reducing the harms from fentanyl. Because for many individuals, a positive result may lead to behavior change and risk reduction. The person who sees that their drugs that they're about to consume has fentanyl in it, they've reported wanting to use a smaller amount, using slower, making sure that they're using with someone, or that they have naloxone available. Those are all steps that we would want someone who is using fentanyl to be aware of in order to reduce their risk of an overdose. The one thing I would say about this is that it's important to identify the right audience and group for these test strips, for this type of intervention. As Robin and I have both sort of mentioned here, there is a subset of the population who is seeking to use fentanyl. Their bodies have now been accustomed to it, they have a high tolerance, and they are looking for fentanyl. But then there is this population who are being accidentally exposed. They are intending to use something like cocaine. They are not intending to be exposed to fentanyl. This latter group is the ones who may benefit most from something like a fentanyl test strip. For the group who are trying to find fentanyl, this is probably not the right intervention because their use is not going to be dissuaded by the presence of fentanyl. Whereas this group who may be using other drugs or using more recreationally, that is the audience who could perhaps most benefit from learning and caring, learning about and caring and using this type of intervention. Next slide, please. My remaining slides here are now talking about xylazine, which you heard just a few minutes or so ago, is really the latest threat that has made its way into our unregulated drug supply. And so this is just a screenshot, or this is the title and the subheading from an article that came out earlier on this year that was published in the New York Times, really sort of focusing on Philadelphia. And I'm happy to sort of share my experiences about that later, just about the widespread now prevalence of xylazine in the drug supply. 90% of opioid samples that are tested in Philadelphia are positive for xylazine. So this drug is very prevalent here. It is sort of the epicenter of xylazine in the US. And as is sort of stated here, is this animal sedative mixed with fentanyl is bringing fresh horror to US drug zones. Next slide, please. Xylazine, as you heard, is a potent veterinary sedative, but not FDA approved for use in humans. It is an alpha-2 adrenergic agonist, so similar in structure to medications that we are all probably collectively more familiar with, such as clonidine or dexmedetomidine. Again, believed to be added to opioids for synergistic effects and or to prolong their effects, particularly that of fentanyl. Its predominant clinical effect is that profound sedation, but can also cause respiratory depression, hypotension, bradycardia, and skin ulceration. And the picture that I put on the right here is also from the New York Times, just a more recent article, but it sort of highlights one of the challenges with regulating the specific supply of xylazine, because for veterinarians and for, in this case, sort of many owners of horses, this is a very important medication. And so we do not want to sort of just quickly say, no, we need to sort of get rid of all xylazine, because what are sort of the other impacts, what are the other consequences of that if we do so? Next slide, please. So xylazine followed the introduction of fentanyl in the East Coast drug supply. And this is why I think it's important that we learn the lessons that we can from what is happening on the East Coast, because just as we are now seeing this, we have now seen this significant influx of fentanyl in California, we should be sort of thinking about, well, xylazine followed fentanyl on the East Coast, it very well could follow into our supply here. And so this graph is from the Philadelphia Department of Public Health and from our medical examiner's office, but it sort of shows just both the increase in deaths involving heroin or fentanyl, which is the height of the gray columns there. And so you can sort of see that we had this very steep rise beginning in 2014, 2015, peaking in 2017 there. And then that dashed line there represents the proportion of those deaths that also involve xylazine. And you can sort of really see there that that increase also really sort of began after fentanyl was introduced into the Philadelphia drug supply. Next slide, please. Xylazine is indeed complicating our clinical and public health responses. And so in this table here, I've tried to sort of highlight what are some of the clinical effects of xylazine on the left, and then how is that pushing us to have our clinical and our public health responses change on the right. So in the first row there, as you've now heard about, xylazine causes profound sedation and is not reversed by naloxone. Parenthetically, naloxone should still be given to reverse the effects of fentanyl, which are almost certainly likely there as well. But how is this changing then our response? Well, it's that if someone has overdosed from a combination of xylazine and fentanyl, and you see the person and they appear unconscious and their breathing has slowed, all the signs and symptoms, all the signs that we are concerned about related to a fentanyl overdose, you want to give naloxone, right? And historically, after you've given naloxone, you push the person into withdrawal and they sort of come to. They wake up pretty aggressively. They may be a little bit confused. They may be uncomfortable because they are experiencing withdrawal from fentanyl or from another opioid. But now imagine you also have xylazine there. Xylazine is not reversed by naloxone. And so now you have reversed the effects of fentanyl. The person is now breathing again, but they may still be unconscious, and they may still appear to be very sedated because of the effects of the lingering xylazine. And so here's our new change in need here is that updated education about what to expect during an opioid reversal are needed. The important point to make here is that the goal of an overdose reversal is not to restore consciousness, it's to restore breathing. And that's what naloxone will do. Naloxone will restore the breathing that had been suppressed from the fentanyl, and therefore it could be life-saving. If the person remains sedated but is breathing, that's okay. You have done what you needed to do to reverse that overdose, so the person is breathing again, and the effects of the xylazine will just slowly wear off. The second point here around the clinical effects of xylazine is that chronic exposure can lead to physiologic dependence and withdrawal. And we need to think about what do those treatment protocols look like to manage that xylazine withdrawal. People who are withdrawing from xylazine are very uncomfortable. They're very agitated. They're very irritable. What medications can we provide to them that can help them overcome some of those withdrawal symptoms and signs? Repeated xylazine injection is associated with necrotic skin wounds. And so what is our response here? Well, increased wound care is likely needed. And there is some concern for more frequent amputations. So thinking about the stress that this may put on our healthcare systems when surgeons may need to be doing more amputations among people who are injecting drugs, for example. We have reportedly heard about this on the East Coast and in Philadelphia. One of my colleagues was looking at doing a study just around this of how much have amputations increased following the introduction of widespread xylazine in Philadelphia's drug supply. And then finally, the clinical effect of xylazine that we still don't really know about is what are the pulmonary impacts when xylazine is smoked? We don't really have an answer to that yet because on the East Coast, xylazine and other drugs are more commonly injected. But this is different from what is happening sort of on the West Coast here and in California. Next slide, please. And that is sort of what I've illustrated on this slide. People who use drugs in San Francisco vastly prefer to smoke their fentanyl as opposed to inject it. And that is sort of what is seen on this graph here. This was an observational cohort study that was done a couple of years or so ago, where researchers repeatedly surveyed about 400 people who use drugs in the city here. And they talked with them about, how are you using the drugs? What is your preferred method of consuming them? Back in 2019, you saw that most people were reporting injecting their opioids. But over time, that same cohort, their number of injections decreased, which is that line in turquoise there, while the number of days that they were smoking fentanyl was increasing. Qualitatively, they did some interviews with these same individuals and found that there was a perception of perceived health benefit of smoking as it compared to injecting. And so as we think about monitoring for what are the effects of our changing drug supply here, it's important that we consider that most people smoke their drugs and what could be some of the pulmonary manifestations of doing so. Next slide, please. I'm going to end here now with what are some of the things that clinicians can do for patients who use drugs. The first of which is, please, thank you for joining today. Please continue to learn about the issues of this unregulated drug supply and how it may affect your patients who use drugs. And that includes referring patients to accurate, up-to-date information without creating alarm or advancing stigma. And so some of the information that I would certainly your local or the state health department here. And I will say this latter part that was important is without creating alarm or advancing stigma. It's very important that we are providing accurate, up-to-date information, but we don't want to create undue hysteria or alarm that could further stigmatize people who use drugs or the drugs that they are choosing to use, because that can certainly dissuade people from opening up and seeking treatment and talking to you about their drug use. Please inform the health department, your local health department or the state health department about any sort of concerning or atypical or unexpected symptoms or signs that you observe. Please learn to prescribe buprenorphine and incorporate it into your practice. And then lastly, please prescribe and dispense naloxone to individuals who use drugs, even if they report predominantly using a stimulant. Because of this concern around accidental or unintentional fentanyl exposure, it's important that we do make sure that everyone who is using drugs, people who know people who are using drugs, are carrying naloxone and know how to use it. Next slide, please. My penultimate slide here is really sort of about xylazine again, and I'm sort of going to reinforce some of the things that Robin just mentioned there is, for xylazine specifically, because there is a lot of attention around this drug in particular, both now locally, but certainly at the national level, as you heard about the federal administration's plan to address it. But please do learn more and get clinical resources via your local health department or the state health department. Some of the URLs are here, and from the California HON, is around testing. Testing for xylazine may be available for suspected xylazine poisoning and can be considered under sort of in these following situations. Again, if there are cases where naloxone appears to be ineffective in reversing a suspected drug overdose, so you've given naloxone and you expected to see the person, the overdose reversed, and you're not seeing that, please report that. When individuals present with concomitant hypotension and bradycardia or cardiac conduction disturbances in the setting of drug use, and then when necrotic skin ulcerations are present in a person with substance use disorder, especially opioid use disorder, are some of the recommendations from that health alert network. Next slide, please. And my last slide here is just sort of some concluding thoughts. As our drug supply changes, because it will continue to do so, our clinical and public health responses must change too. However, our care and compassion should not waver, and efforts are needed to reduce the stigma in clinical settings. And so my last part thought here is that, again, thank you for joining. Thank you for being here. Thank you for listening and learning. And I look forward to your questions, but please share this information with your colleagues as well, because healthcare professionals in all settings can treat and support the needs of people who use drugs. So thank you very much.
Thank you so much, Jeff. And Robin, you can join us. This has been so incredibly helpful both from sort of an overview and also really super clinically relevant information for all of us. We have loads of questions we probably can't get to, but we'll do our best. So the first question was that, Jeff, you gave such a great summary of some of the new and changing needs in treatment and reversal in opioid use. And it seems like right now, those protocols are in separate papers, and you really have to either come and watch this webinar, and hopefully those of you on the call will be able to share it widely with colleagues, but also you have to find those papers and those specific treatment protocols. And I'd just love to ask you both if there's plans or ways through the KHUN and some of those other networks and resources where it's sort of a central place that people can go to as those to look at those protocols so that they can use them for themselves.
So speaking from like the state's perspective, I think that's a great question. That's one of the things that we are trying to accomplish with our Xylazine webpage. I did just share the links in the chat with the organizers, so maybe those can be shared out in the chat for all of the attendees as well. It is a page that's going to be evolving over time. This is really an ever-changing, ever-evolving landscape in terms of best practices in clinical care, and we are trying our best to stay up to date. And I think for a while, it will be a little bit of that. It will be a little bit of different documents in different places, and then as we start to identify what these best practices are, we'll be able to house those on our website as well.
Great, thanks. I think those resources will be really helpful for clinicians in the field. A lot of people had questions about emergency management of acute overdose. And one of the questions was, you talked, Jeff, a lot about fentanyl reversal, but are any of the xylazine reversal agents, one of our participants mentioned one that's used in veterinary medicine being explored for human use?
That's a great question. Let me first by saying I don't know. I'm aware that there are reversal agents for a number of different sort of medications, and there are risks and benefits to always sort of using these medications. With naloxone is such a safe, effective, easy to use medication that can very quickly reverse the effects of opioids, including fentanyl. But there's also other medications that we do not, generally speaking, prescribe that are reversal agents, such as the one that we use for benzodiazepine overdoses, because of the risk, the concern about potentially precipitating a seizure. Naloxone does not have that risk, but that is a reason why we do not liberally prescribe the reversal medication for benzodiazepines. I think with xylazine, we're still in such an early phase of understanding its properties, and so I think I don't have information on what may be looked at from the FDA or some other sort of veterinary practices. So I cannot speak to sort of that, but just sort of thinking through what are the risks and benefits of providing these, although I do recognize the importance of thinking about medications like this.
And then what about sort of more public health and systemic approaches to reversal in broader settings? So are there programs in California for example, naloxone distribution in schools or homeless shelters in jails and prisons? Robin, maybe you can talk to that, and Jeff, tell us what you know as well.
I think there are a number of programs within California. I'd be happy to talk a little bit about, we have a statewide standing order that authorizes the distribution and administration of naloxone that would be available to people without an individual prescription. We are all probably well aware that Narcan, one of the naloxone products, will be made over the counter in hopefully just a few weeks or months, if not this summer. So yes, there are a number of systems in place within the state to help to support that. Our statewide standing order bolsters the DHCS naloxone distribution program, which allows a number of community-based organizations, schools, libraries, and other entities that are serving the public to have no-cost naloxone delivered straight to them. So we have a network within our state of over 68 safe syringe services programs, and they are the boots on the ground distributing naloxone directly to people who need it most.
Yeah, Jeff.
Oh, thanks, Kim. Sorry. The one thing I would sort of also add to is one, certainly thank you to the state for really making naloxone as available as possible. I think that from the Naloxone Distribution Project and other entities, really the state I know is endeavoring to make naloxone as available as possible and really thinking about all the different venues in which naloxone may be needed. And so as all of you sort of in the audience here think about that, I would sort of say from my perspective, at least in San Francisco, we've been really sort of encouraging different sort of groups who do work with individuals who are in entertainment, the entertainment industry. And we have a new partnership with the Entertainment Commission here, thinking about naloxone and fentanyl test strips being available. We have worked with the school. We are working with other city departments, recognizing that we all may be in a position to save a life.
Well, speaking of which, I know a couple of physicians who carry Narcan who've written themselves prescriptions or got them from their own healthcare providers. Should we all be thinking of ourselves as first responders these days with this being such an epidemic? Any specific thoughts or recommendations on whether those of us who are just citizen healthcare providers should be carrying Narcan?
Wearing my public health hat, I love the sound of that. I absolutely love the sound of that. I carry Narcan with me. We have it in the car. I have it nearby so that I can use it as a tool as I'm talking to folks. I really truly believe in the socialization and normalization of having life-saving options because we can all save a life. It's important to recognize the signs of an overdose and to educate the public on how to recognize the signs of an overdose and how to intervene by administering naloxone and calling 911.
Amazing. I love that you have your kit right there. We didn't plan this. We don't have much time, but I have a couple of quick questions about special populations. How about Tranq and pregnancy? Do we know anything about risks to the unborn fetus?
I do not, Jeff.
I have not seen any sort of published literature around that. I know there were 2 studies that were underway when I left the Philadelphia Department of Public Health. It's a good, important question. I don't know the answer, but I'm hoping that in the near future, we will have some information about that.
Okay, great. And then as a pediatrician, I loved seeing this question come in about treatment for youth with opioid use disorder in California. Anything special we should know when thinking about or treating youth?
That is a great question. Medication for opioid use disorder is available, and options like buprenorphine and methadone should work also for the pediatric population. I would defer to the package insert and also information from the drug companies themselves in terms of how it's been tested on pediatric populations, but I can say that anecdotally we are aware of a number of addiction medicine physicians who are prescribing buprenorphine to pediatric population.
Great. Yeah, most of the medications we use are off-label, not tested on children, so we're quite used to that as a physician population, unfortunately. One last question people are asking about are Xylazine detection kits, like point of care kits, sort of strips like you showed the one for fentanyl, coming available? Any thoughts or insights on that?
Xylazine test strips are available currently. We are working as a state to make sure that they are available through our harm reduction clearinghouse, which is made available to our syringe services programs across the state. Those should be available to the syringe services programs in the next few weeks. We're rolling this out in a pilot phase, so we are still uncertain as to how well they will perform in the real world application. They are literally brand new. I believe they were introduced to the market this calendar year. So we are watching and waiting to see how well they perform and how useful they are. I will say though, that in terms of like a clinician at point of care testing, that is part of the National Drug Control response to Xylazine. They are really working to identify better tests that perform well at point of care. Hope for better options in the future.
Yeah, great. Well, yeah, Jeff, dive in.
Sorry, just to build one last point on what Robin sort of mentioned there too, is I think that we still have much to learn around the Xylazine test strips. But I would say the other benefit as we sort of think about all of these different supplies, including a strip like that, which will have its own limitations, is to think about also how these are engagement tools. how it opens a conversation around sort of an unregulated drug supply, the risks that someone the consequences someone may be at risk for, and then how we can provide some information to help keep people safer. So these tools, I think, have their utility in providing information when used in sort of the right setting. But even with those limitations, they can really still be ways in which we can open up a conversation with more of our patients. So I'll just end with that. Thank you, Ken.
I love that you ended with that. And I just want to say this has been such a helpful and interesting conversation. I really appreciate the way that both of you approach this from such a science and evidence-based point of view, but also with such humanity at the core of it, really thinking both about individuals and also at the system and public health level. So really appreciate you both today. I'm so grateful you're here. Thank you to everyone who's listening in and taking the time to learn about our webinar. And I do want to remind you all that this broadcast will be available forever on our website. You could go to covidroundsca.org. So please share it with your colleagues so that we can really get the word out about this emerging threat. Reminder that you will receive a survey at about 5 p.m. today, and you can attest your attendance to get your CME. And then our next session will be Tuesday, August 9th, and that session will be on some issues around emerging new vaccines like RSV vaccine and some new updates on contagious diseases in schools and how we think about those. So super grateful for your participation and have a wonderful day, everyone.